I'm Leslie. I'm a third-year cardiology fellow at the University of Texas Health Science Center at Houston. And right now may be the most exciting event for me at ACC this weekend. We have a special privilege to chat with Dr. David Austin from the United Kingdom. And of course, Dr. Austin is the principal investigator of the PROACT trial, amongst others, such as tactic and fractal trials. And Dr. Austin, you're very well known in kind of your leadership role in making sure there's high quality research in the United Kingdom. Very respected interventional cardiologist at the South Tees hospitals in the UK, and the co-director of the academic cardiovascular unit. Dr. Austin, thanks for being with us and saying yes to FITsOnTheGo.
Okay, thank you, Leslie, for inviting me, and it's a pleasure to be here.
Me too. So of course, since I have you here, I have to ask you about the big trial. Can you tell us a little bit about PROACT and maybe some of the few take-home points that you'd like us fellows to know about it?
Okay, so the PROACT trial is a trial in the field of cardio-oncology. It's a multi-center randomized control trial looking at patients with breast cancer or non-Hodgkin lymphoma who are receiving high-dose anthracycline chemotherapy. So anthracycline chemotherapy would be doxorubicin or epirubicin, for example. We know that those chemotherapies, particularly when they're given in high doses, are associated with a cardiac injury and cardiac dysfunction, and in a smaller proportion of patients, later heart failure. And obviously that's an important issue for the increasing proportion of cancer survivors. And that's obviously one of the major drivers behind cardio-oncology, is improving the quality of the survivorship of the patients. So the PROACT trial is randomizing patients to either enalapril, the ACE inhibitor enalapril, or to standard of care. So it's an open label study. And we are looking to see whether the patients have reduced myocardial injury during chemotherapy, measured by cardiac troponin. And also we have markers of cardiac function measured by echocardiography. So this study was performed in 13 UK hospitals between 2017 and obviously with the pandemic interfering, we finished it in 2013. And this is the primary report at this conference.
Thanks, Dr. Austin. That was a really great kind of summary to piece it all together. And one thing I wanted to ask you was that looking at how with anthracycline cardiomyopathy, it's very dose related. And looking at your population, breast cancer patients who tend to get lower doses versus the lymphoma population who tends to get a higher doses of anthracycline. I'm curious to know, what is the division? How did your sample size turn out, your N number for the breast cancer patients and also for your lymphoma patients in PROACT?
Yeah, so that's a good question. The sort of USP of PROACT was to go after the patients who were going to receive the highest possible doses. And so there was a group of patients within the breast cancer population who still received quite high dose anthracyclines. And so those patients are 60% of the PROACT trial population, with the remainder being the non-Hodgkin lymphoma group. And we stipulated that the patients should have a minimum of more than 300 milligrams per meter squared of doxorubicin. And the permitted cycles essentially meant that was going to be the case. But you're right to point out that oncology moves on, which makes cardio-oncology a little bit of a moving target. And quite a lot of breast cancer chemotherapy regimens do include lower doses these days. And so that's the reason why we extended the trial in the early stage to include the non-Hodgkin lymphoma patients, to maintain the integrity of our study question, which was to look at the highest possible doses.
And I think that's awesome. I was actually talking to one of my attendings at MD Anderson, and one thing that he loved about your study was just the fact that you also looked at lymphoma patients, because in the current advent, there's a paradigm shift in the breast cancer realm to kind of try to stay away from anthracyclines, especially in the younger population. So I think in this term, using enalapril is still kind of relevant when we talk about lymphoma patients.
Yeah, I think so, yeah. And of course, when you're designing a clinical trial, of course, you also need to think about your event rates. How often is your event going to occur? If you're going to study low dose patients, then the events are going to occur less frequently.
Not as much.
And so you have to then study more patients to have a statistical power.
Right.
So, some of this is about study design and about understanding this as an enriched population in this particular trial. So we studied fewer patients, but at higher dose. And the idea is that, you can then have the adequate power to answer your question to the satisfaction of everyone who will read your study in the end of it all.
Okay. And then the other thing was that looking at, you kind of mentioned some of your endpoints. I am curious about looking at whether you think later on maybe your study is heading a way where you would like to look at global longitudinal strain, for example, or end systolic volume, which are more parameters that we have known in the past to be predictive of mortality when it comes to end systolic volume, and also maybe predictive factor of a decline in AF when it comes to GLS, for example. Do you have kind of any prediction, do you think, of incorporating these endpoints in your next study or the future of PROACT?
So PROACT also includes, so the primary endpoint of PROACT was the myocardial injury, but we also looked at global longitudinal strain as part of PROACT. And you're right to point out that that's had quite a lot of interest, particularly in cardio-oncology.
Right.
The SUCCOR trial, I don't know if you're familiar with, used GLS to predict.
Yes.
And so yes, we've included GLS as part of the secondary endpoints in PROACT. And we're also going to be following these patients up longer term to look at ejection fraction clinical endpoints over time.
That's great. And then my last question is that what do you see as kind of some of the pitfalls that you foresee when it comes to generalizability of using enalapril in our breast cancer patients and also lymphoma patients?
So we found that enalapril did not impact either the cardiac troponin T or cardiac troponin I in the chemotherapy period and the immediate post-chemotherapy period. So we did not find that enalapril reduced the mild CTR-CD, as it would be called, cancer therapy-related cardiac dysfunction. And also, this was consistent with the secondary endpoints of the study. So around 1 in 5 patients had a reduced GLS by more than 15% from baseline. But this did not differ between the enalapril group and the standard of care group. So essentially, we didn't find evidence that enalapril was beneficial in this high-dose anthracycline group. So in terms of generalizing that, I guess I would be saying that this shouldn't be part of a sort of standard of care for all patients undergoing high-dose anthracycline chemotherapy. And I think this remains an open question in cardio-oncology as to how best we are to tackle this. Is it to monitor patients? How do we monitor patients? How closely do we monitor patients? And I think that remains an open question, but I don't think enalapril as a sort of primary prevention treatment strategy would merit any larger scale clinical endpoint trial after the results of PROACT.
And I like how you point that out, because I think one of the main challenges we have in the realm of cardio-oncology is this trying to find or increase our momentum in the protective strategies in cardiomyopathy that are chemo-related. So thank you, Dr. Austin, for giving us a preview of PROACT. And to watch more videos like this, please check out youtube.com/FITsOnTheGo and follow us on X @FITsOnTheGo.